Hey everybody, I wanted to film a quick video today talking about the difference between hypertensive emergency and hypertensive urgency. This is a very common topic that can get confused with people from time to time. And I wanted to kind of just talk about it, whether you have high blood pressure or you're a clinician, a medical student, whatever. This is a really important topic to understand. So hypertensive emergency and hypertensive urgency really have the same blood pressure cutoff, which is probably one of the more confusing things, right? A blood pressure cutoff of 180 over 120 is going to be known as whether hypertensive emergency or hypertensive urgency. So again, 180 is the systolic number, 120 is the diastolic number. Remember, the American Heart Association updates these guidelines frequently, and recently we've been seeing blood pressure of 120 over 80 being normal blood pressure. Anything above that might just start getting to the elevated range, and then of course you have different classes of high blood pressure as well. But regardless, hypertensive emergency and hypertensive urgency have a blood pressure of 180 over 120, and many times it could even be greater than that as well. Now, the difference between hypertensive emergency and hypertensive urgency is the fact that hypertensive emergency is going to present with these end organ damage type of symptoms, and things like end organ damage could occur in the eyes, right? They can occur in the heart. It can occur in the brain. It can occur in the kidneys. So let's kind of go through these things that would occur, right? So let's say a patient comes into the emergency department, their blood pressure is 190 over 140, they're complaining of changes in vision, and they're maybe starting to complain of the ability or the inability to speak properly, right? Well, I would start to think, well, they might be having some sort of stroke, right? Or they might be having a cerebral vascular accident. They might even have a subarachnoid hemorrhage at a blood pressure that's that high. So you've got to kind of keep in mind, hey, if a person's coming in, they're complaining of visual symptoms, they're complaining of brain, dysfunction, whether it's lack of speech, whether it's, again, going to be, the trouble, thinking, things like that. You might be thinking of, well, hey, this person might be having a stroke due to that 190 over 130 blood pressure. Could also have a heart attack, right? Let's say somebody comes in with chest pain and they're complaining of shortness of breath, and they have this chest pain radiating into their left arm, again, kind of that classic heart attack scenario. You might be thinking of, well, their blood pressure is 190 over 130, they might be having a heart attack. Finally, things that we could see sometimes in patients that have this maybe common high blood pressure, then they have some sort of acute exacerbation, and they have this hypertensive emergency. They could have something like, kidney damage, right? They could have hypertensive nephrosclerosis, right? And that's going to be the idea that your renal arteries and, the different vasculature inside the actual kidney, right? There's many different, interlobular arteries, interlobar arteries. You might have changes in the vascular wall, right? And the blood's not getting to the kidney. So the kidney's becoming ischemic and it's becoming damaged, right? It's not getting that O2, it's not getting those nutrients, it's not getting the proper blood supply, and that's causing an increase in creatinine, right? So CR is the abbreviation, for creatinine. You have potassium and sodium dysfunction, right? Again, we could have the idea that these electrolytes are all over, and that could cause further problems, right? So that's really, really important to kind of realize that if somebody's presenting to the emergency department that you're working at, or whether it's your clinic or whatever, and they're telling you, hey, I'm having these symptoms, and you do a blood pressure reading and you see this, you should immediately be thinking about a hypertensive emergency. Now, of course, sometimes some patients are more sensitive to high blood pressure than others. Somebody might not have the exact cutoff, and technically they don't have the hypertensive emergency based on the cutoff, but they might be complaining of end organ symptoms. Maybe they're complaining of visual dysfunction or, heart attack symptoms. You always want to, again, listen to the patient, figure out, are they having chronic hypertension? Are they having an exacerbation of hypertension? And again, then you can actually, treat them best. On an exam, though, most of the time they're going to tell you this person has a blood pressure of 185 over 125. What are they having? And they're going to have changes in vision, changes in their chest with, chest pain and radiating to the left arm. Well, you should be thinking of, it's going to be a hypertensive emergency. Now, the big thing is, how do we treat a hypertensive emergency? Well, the way we treat a hypertensive emergency is, multiple ways we could actually do it, right? We can do, we could treat a hypertensive emergency, via a few things, right? We can treat a hypertensive emergency via giving this person something like esmolol, which is a beta blocker, right? It's a cardioselective beta blocker. It's a beta 1 cardioselective. Remember, beta 1, again, receptors are found on the heart and they respond to like norepinephrine and epinephrine. Again, then you also, again, have nicardipine, right? Nicardipine is a calcium channel blocker. Remember, it's a dihydropyridine calcium channel blocker, which means that it's not going to have an effect on the conduction of the heart, but it's going to have an effect on the vasculature out the systemic areas of the body, and that's going to cause a decreased afterload, and again, it's going to cause decreased pressure in the vasculature. And then you can also have something that isn't commonly used anymore, at least in the ICU that I work at. We don't really use nitroprusside anymore. Again, we just kind of use esmolol or nicardipine as directed. Again, blood pressure of 160 over 100 would be really important, right? That's going to be you want to target that number within the first 2 to 6 hours, and ideally you would like to decrease your blood pressure from 180 over 120 by about 25% within the first hour, right? So the first 60 minutes, you would like to decrease that blood pressure by about 25%, and you want to get to a number of 160 over 100 after the next 2 to 6 hours. So really within the first 3 to 7 hours, your blood pressure should be somewhere around 160 over 100. And then again, you're using esmolol IV, nicardipine IV, or nitroprusside IV. Another big thing to kind of keep in mind, over the next 2 to 6 days, maybe a week or so, we want to manage that blood pressure, right? You want to put somebody maybe on, maybe an ACE inhibitor, for example, or maybe a beta blocker. You want to do something to decrease that blood pressure, right? Again, what beta blocker are you choosing is really important, right? You want to, make sure that you're treating that blood pressure and making sure that the patient is feeling good. Hypertensive urgency, like we said in the beginning, again, blood pressure is still 180 over 120 minimum. The big difference between that is that there's going to be no end organ damage type of symptoms going on. So these people are going to not be complaining of visual changes, not be complaining of chest pain. They're going to be telling you, hey, I might be feeling a little off, but it's not going to be, there's no direct evidence of end organ damage. And these individuals, again, we really need to, still treat their blood pressure. We still want to bring it down, but again, it's not causing that end organ damage that we saw with the hypertensive emergency. Now, one caveat of all of this, with any time that a patient presents with such a high blood pressure, you really want to be careful that you don't lower the blood pressure immediately to, let's say, you don't want to go from 180 over 120 back down to 120 over 80. What that's actually going to do is it's going to cause a rebound ischemia in their system, right? So they might actually end up having an ischemic stroke. They might end up having some sort of ischemic kidney damage, ischemic damage to the heart, because their body has kind of accustomed to this new homeostasis of 180 over 120 or higher, and you don't want to drop it that fast. So again, really take great care in dropping it 25% or so in the first hour, and then in the next 2 to 6 hours, targeting that 160 over 100, and then over the next few days, making sure that you get down to a value that is appropriate. Again, 120 over 80 or lower is ideal, but again, 130 to over 80 is also completely fine for most people as well. But again, that's the one thing about blood pressure, right? We tailor it to each individual patient. One thing I kind of failed to mention earlier was that, again, with a hypertensive emergency, you can also have sexual and vascular dysfunction and changes. Again, same reason why all of these things are occurring. It's because the blood vessel wall is damaged, right? When you look at a blood vessel wall, so let's just draw kind of the cross section here of an artery. What happens is you either have processes over time, right? You can have something called hyperplastic, arteriosclerosis, and this is going to be usually associated again with this kind of benign hypertension, and over time the blood vessel wall is going to change and it's going to narrow down. So again, if this narrows, right, so let's say this goes from like the cross section here to the cross section of like this, and it narrows, well, you're going to see again an increase. This is going to cause here an increase in blood pressure, right? So you get a hypertension most likely. You can also have another process called hyaline arteriosclerosis, which is a different, more hypertensive emergency type process occurring, right? And again, hyaline arteriosclerosis, where everything narrowing because of high blood pressure, you'll get something called onion skinning. And that's going to look like, onion skinning looks this way under histology, right? Of course. So under the microscope, you'll see that. So again, kind of an important video, I think, at least understanding the differences between hypertensive emergency and hypertensive urgency, realizing that hypertensive emergency is a medical emergency. Again, the patient presents with a blood pressure that's 180 over 120 or greater with the signs of end organ damage, whether it's, again, vascular, sexual, again, heart attack, stroke, etc. Something's going on with them. They're complaining of symptoms. You must lower the blood pressure 25% within the first hour and then target 160 over 100 in the next 2 to 6 hours. And then finally, you have hypertensive urgency, again, 180 over 120 or greater. The big difference being this doesn't have any end organ damage being present. So thank you guys for watching this. I hope you enjoyed this video.